Welcome to the second session of the WTO Climate Course for Global Gastroenterology. My name is Carolina Olano. I am Professor of Gastroenterology in Montevideo, Uruguay, and Secretary General of WTO. I would like to thank the course director, Desmond Leddin, and the steering committee for the invitation to chair the session. Climate change is a rapidly developing public health crisis and significant digestive health and disease implications. Healthcare providers involved in digestive care need to understand the challenge we face. So our goals today are to raise awareness and educate about these critical global issues. I will share my screen to show you our moderators today. Professor Chen is Professor of Medicine at the South Hospital Nanfang Medical University and at Guangzhou, China. She is a committee member of the Chinese Society of Gastroenterology and member of the WTO Clinical Research Committee and the WTO Climate Change Working Group. Professor Elias Makhoul is affiliated with the University Hospital Notre Dame des Secours in Byblos, Lebanon. In addition to WTO Climate Change Working Group, he is also a member of the WTO Endoscopy, Other Procedures and Outreach Interest Group. He was awarded the Masters of WTO at the World Congress of Gastroenterology in 2022. During the session, we will be very happy to receive your questions through the Q&A box so that at the end of the sessions, the moderator will use your questions in the discussion. We have also two leading experts as presenters today. First, Nicholas Talley is a distinguished Laureate professor at the School of Medicine and Public Health at the University of Newcastle in Australia. He is editor-in-chief of the Medical Journal of Australia and a member of National Health and Medical Research Council, past president of the Royal Australasian College of Physicians, past chair of the Council of Presidents of Medical Colleges, and former treasurer of the Australian Academy of Health and Medical Science. In these roles, he has advocated for leaders from the government and the healthcare sector to take more significant actions on climate change. The second speaker will be Mary Donnelly, an hepatologist at the Royal Infirmary of Edinburgh in United Kingdom. She is an NHS hepatologist with interest in acute liver injury and acute liver failure, liver transplantation, and palliative care in liver disease. She is the lead author of the Negative Bidirectional Interaction between Climate Change and the Prevalence of Care of Liver Disease, a British Society of Gastroenterology, British Association of the Study of the Liver, European Association of the Study of the Liver, and American Association of the Study of the Liver commentary. Please, Tim, could you please launch the first talk?
Welcome. I'm going to be talking today about the climate change emergency. I'm going to be discussing how will climate change affect digestive health and disease and what should you do about it. And I want to thank the World Gastroenterology Organization for the opportunity to present this webinar. I'm speaking to you from Australia, from Newcastle, Australia, or Wabbagal land, and I want to acknowledge the traditional custodians of the land on which I am today and the lands on which you are today, and pay my respects to elders past, present, and emerging. It's very interesting in Australia. We've been real laggards in addressing the climate emergency that is clearly with us today. And this is despite extreme bushfires, extreme rain and flooding, and other serious events that have occurred in Australia over the last just few years, it's very clear those events are increasing in frequency. And we're seeing, for example, floods that would have been 1 in 100 years, 1 in 1,000 years, occurring almost annually, for example. That doesn't mean everyone's convinced there is a climate emergency. In Australia, there have been politicians and groups advocating that there isn't a problem. Some of these groups and others are sponsored by or supported by the fossil fuel industry, which is a little bit alarming. And you'll even see newspaper reports when there's, for example, a large snowfall in the snowy mountains of Australia, arguing perhaps there isn't such a problem to worry about. And that, of course, is given press until the next flood, until the next bushfire emergency. If you're any doubt about what the scientists think, look at the Intergovernmental Panel on Climate Change, the most recent of which was published in 2021. It leaves no scientific doubt we have a global warming situation. It's real, it's largely human-made, and it's causing significant weather and other events. And we are expected now around the world to see more frequent and intense heat events, rains and cyclones, droughts, fires, ocean warming, loss of coral, acidification of the oceans, and other changes that will be very serious. When I was the editor of the Medical Journal of Australia, we began working with the Lancet for a countdown on health and climate change, and the latest version of this was published in 2022. It makes very sobering reading for those of us in Australia, and indeed the title of this, Australia Unprepared and Paying the Price, is very germane. We've also summarised in the MJA the science of climate change for doctors, so we could help educate us, all of us, about this issue. And so the science would be clear for doctors who may not fully appreciate what has been happening. It's sobering to realise current temperatures will be even higher except for the cooling of air pollution. And nobody wants air pollution, but that's the case. And we're heading for a temperature now of around 3 to 4 degrees if we don't turn things around fairly dramatically. And that includes turning things around in the health system and in gastroenterology practice if we're to make a real difference. Some have argued we may need to take CO2 out of the atmosphere to really succeed in this global emergency. And I guess my summary of all of this is once you read the science, if you're not frightened, you should be. And I'm frightened particularly for my children and their children going forward. You'll also hear arguments about, well, CO2 is good for plants. Excess CO2 means actually this is a good event and it will be good that there'll be global warming. The trouble is this view is not only overly simplistic, completely simplistic, but plain wrong. Yes, some plants will thrive in a higher CO2 and warmer environment, but many of the plants that we rely on for our food supply will not do well in this situation. So it's always a bit of yin and yang. Some good things, mostly bad, though, with climate change. And the real issue with climate change is that we are much better able to adapt to cold environments than to warm environments or very warm environments. Our ability as humans to adapt to heat, to survive extreme heat events is limited. And this is the problem that we are going to face globally as the situation worsens. What about the implications for gastrointestinal disease? And I'll focus primarily on gastrointestinal tract disease, not on liver disease in this presentation, as this will be covered on liver disease in another presentation. Well, this is a very nice diagram that summarises some of the adverse events that will occur as the climate crisis continues to unfold with global warming. Yes, we'll see worse events, more fires, more floods, more deaths directly, and that will also have adverse mental health effects on the population, which in turn will likely promote increased gastrointestinal diseases, such as the functional gastrointestinal diseases. We'll also probably see more alcohol use and more drug use, which will also have negative impacts on the gastrointestinal tract, including increased risk of GI cancers. And in some parts of the world, we will certainly see more malnutrition and those effects on the gut as well. As greenhouse gas emissions increase, we'll see more particulate pollution, which I'll talk about in a moment. That in turn can also have direct negative effects on the gastrointestinal tract and increased risk of disease. We'll also see food insecurity, which will probably lead to even more use of refined foods, which in turn are risk factors for obesity, as well as societal disruption that will in turn cause other health problems that we will see. All in all, it's a rather depressing picture of what we face and the worsening disease burden we will face in gastroenterology going forward. So as an example, toxic material in smoke is rather deadly. There's good evidence now that exposure to very fine particulate matter, PM2.5 and smaller, that is a significant risk for increased premature mortality. And that premature mortality is from increased cardiovascular events, increased respiratory diseases, and increased cancers, including lung cancer. There's also emerging evidence that chronic exposure to these toxic materials in smoke can lead to changes in gut bacteria and gut dysbiosis, the long-term effects of which we still don't fully understand. But there is emerging evidence that there is an increased risk of irritable bowel syndrome with exposure to PM2.5 particles and possibly other chronic gastrointestinal inflammatory diseases as well, although that's less clear-cut. There's also good evidence that enteric infections will increase, or many will increase, with a warming planet. This just appeared in Lancet Planetary Health, a meta-analysis of 40 studies looking at pathogen-specific risks of climate change, and for every 1 degree temperature rise, there will be a clear increased risk of a number of different bacterial enteritises, including salmonellosis, shigellosis, campylobacter, E. coli, and in parts of the world which are impacted, cholera and typhoid. What's interesting is while these very unpleasant and potentially deadly bacterial diseases will increase, some viral enteritis will probably decrease as the climate warms, and that's rotavirus and norovirus, due to viral survival, it's believed. So again, the effects of climate change are complex. They're not black and white, but there's good evidence we will face more gastrointestinal disease as the years go on. This means our leadership of societies, our leaders in societies need to take steps to plan for how we will deal with climate change in gastrointestinal practice, and also how we will contribute to reducing emissions with climate change. And the BSG, for example, has come up with a very nice 5-year strategy. It's clear we need every gastrointestinal society in all parts of the world to come up with similar 5-year strategies and to actually measure outcomes and ensure we're making progress in reducing emissions, reducing waste, and doing our bit for improving climate change. There are barriers to this, though, clear barriers. It can be costly to institute climate change improvements, and they need to be overcome. But it's such an important issue, we must do so. There are issues around knowledge and education of our own colleagues, of our leadership in some parts of the world, and that also needs to change. And there are some psychological issues, including, for example, some who feel they'd rather ignore this than face it, who feel it's really someone else's problem, not theirs. But in fact, climate change is everyone's problem. All of us need to pay attention. The endoscopy unit is certainly a place we can make a difference as part of our practice. This will be covered in other presentations. I'm just going to emphasise that there are clearly a number of different areas where greening endoscopy would reduce emissions, reduce waste, and certainly show we're serious about climate change and dealing with this as a profession, as doctors in society. Obviously, we need to teach and train our staff, our students and others. We can reduce waste, we can recycle, we can reuse, and all of that is critically important. And education and research are critical underpinning parts of this if we're going to succeed in establishing ways of minimising waste effectively, and there are some excellent examples of what can be done published in the literature and summarised on this slide. Reusing materials rather than throwing away materials that we can reuse is so critical, and ensuring we don't develop procedures that waste more rather than less. And then obviously recycling when and if we can, and doing our very best to ensure we maximise recycling of endoscopy waste. And one really obvious example that affects most of us is the receiving of journals from our professional societies, journals that are paper journals covered in plastic that arrive in the mail. Well, just think about this. All of that plastic we use and throw away at home is a total waste and will only further damage the environment, as it's really not able to be got rid of except in waste disposal areas that are filling to the brim. So surely we've got to reduce our use of plastic, and then the use of paper in this day and age of digital really is completely unnecessary. So I urge all of you to contact your societies if you're receiving paper copies of your journals and ask for them to stop producing them, to stop sending them, and read it online. That is the modern way, the sensible way, the only way forward here. And it would certainly demonstrate we're serious about doing something about this. We've also got to take personal responsibility. This is a really nice paper from an individual whose carbon footprint in 2018 is summarised. This is an individual who lives with his partner in the northern United States, but they do own an electric vehicle. And you can see, for example, for this particular individual, air travel was one of the major carbon-producing activities. There were others, of course, but one of the major and one of the obvious ones that could be cut by this individual, by all of us, by doing more meetings by Zoom, not all perhaps, but more, and ensuring that we minimise our footprint where we can. Another paper summarising the CO2 emission from different ways of getting to gastrointestinal meetings is informative, and obviously going by some forms of public transport, such as train or bus, is certainly better than driving a car or taking a short haul flight. So what can you do? What can you do about climate change? What should you do? The first thing you should do is realise you are responsible We are all responsible for what we do personally and professionally here. And I think we'll be judged by future generations about our actions now. And if we take not enough action, we can expect to have that judgment be very poor going forward. We're at high risk of disease, not only gastrointestinal disease, but all sorts of other diseases. We're at high risk of societal breakdown. And so we've got to do more and much more than we currently have. And the health system, as I've already said, contributes a significant amount of the global production of CO2, and we need to do something about this in our departments, in our hospitals, in our practices. I'd argue, as this article does, we have a duty of care to educate ourselves, to do more research, research that leads to outcomes that make a difference. We need to build resilience, but we must decarbonise and promote decarbonisation. And we need to speak out about this, all of us, because if we speak out as a profession, we'll make a difference. So I'll ask you to think about what is your hospital doing about your gastroenterology practice and CO2 emissions. Are you doing anything? Is the department doing anything? Is endoscopy doing anything? And if not, why not? I know, for example, that the hospital I work in has a very bold plan to become carbon and waste neutral by 2030. I'd argue every hospital in the world needs to do the same. We won't all succeed by 2030, but if we aim to do so, it could make a huge difference. And yes, we do need to speak out not only to our profession, but to our patients, to our friends, to our colleagues. Because if we don't make our voices heard, we really will have trouble making any kind of significant difference. Organisations that we lead, we need to make differences. For example, the MJA, the publisher of the MJA, divested from fossil fuels and focused on sustainability as part of its action to make a difference with climate change. And other organisations you're involved with can all do the same. And if you're asking what can gastro societies, endoscopy centres, practices, publishers, individuals and academic centres do to support planetary health, there's an excellent article that appeared in Gastroenterology and Gut and the Journal of Clinical Gastroenterology, which summarises a number of different approaches we can all take to make a difference. That includes making climate change part of or efforts to address climate change part of our daily life, endoscopy approaches to improving the situation with waste and reducing the carbon footprint, recycling where we can, avoiding plastic waste, insisting there isn't plastic waste, educating others, advocating for at government and other levels, providing research support, and teaching our students all about this. And if we do it, if we take these steps collectively, success will come. In my view, leadership like this will make a huge difference because we won't just impact gastroenterology, we'll impact medicine, the health system, and the community. So advocacy on climate change matters. We have a duty of care, and I very much hope you'll all be inspired to do more because each of us can do more in this situation. And I want to point out to you, you will be asked by the next generation, I expect, you will be asked, what did you do about climate change? And I hope you'll be able to answer in a way that is positive and reflects well on this wonderful profession. Thank you.
Thank you, Dr. Talley. I want to remind you that we are waiting for your questions through the Q&A box. The next talk will be on the implications of climate change for liver care. Jim, could you please launch Professor Donnelly's video?
My name is Dr. Mary Donnelly and I'm a consultant hepatologist in the Royal Infirmary of Edinburgh in the UK. Thank you to the organisers for the invitation to speak today on the implications of climate change for liver care. I'm really delighted that the association between climate change, liver disease and the delivery of liver services has been recognised and included in this programme for discussion. Over the next 20 minutes, I will be discussing firstly how climate change is increasing the burden of a variety of liver diseases, with a focus really on metabolic liver disease. And secondly, how addressing the climate crisis affords us an opportunity to change for the better how we deliver healthcare services to our patients with liver disease. To those of us with an interest in this area, there's no doubt that climate change is resulting in an increasing burden of a wide variety of liver diseases. However, this association and the impact then of caring for our patients with liver disease upon the environment is less well understood and less well publicised compared with the link between climate change, sustainability and gastrointestinal endoscopy, for example. So you may not yet have considered the different ways that climate change can affect the liver. There are many different ways, and the risks of climate change are very relevant to us across the whole world and will continue to become increasingly so. Broadly, climate change can impact upon liver health and disease through changes in cellular functions, for example, and in the setting of extreme heat can even lead to acute liver failure. Climate change is associated with increased exposure to a number of toxins and viruses. Climate change is also associated with negative impacts upon mental health, which may result in substance misuse. And importantly, there is an association between climate change, undernutrition and obesity, which may lead to the development of metabolic liver disease. So we will look at some of these associations in more detail. Climate change is associated with increased exposure to and a change in the geographical distribution of a number of pathogens which are hepatotoxic. Increasing ambient temperatures as a result of climate change have been shown to be associated with increased aflatoxin production, which of course is a cofactor for the development of primary liver cancer. And increasing ambient temperatures have also been associated with a change in the geographical distribution of both schistosomiasis and liver fluke. Contamination of drinking water through climate change related flooding, for example, leads to outbreaks of hepatitis A and E. And there is emerging evidence that the contamination of water with cyanobacteria facilitates the progression of NAFLD through alterations in lipid metabolism. So this rather complex figure details the multifactorial and bidirectional relationship between climate change and liver disease. And I'd like to use this figure to focus in on metabolic liver disease. So climate change and the resulting extreme weather scenarios such as heat, fire, flooding, pollution and drought negatively affect agriculture, and it affects how food is grown, how it's transported and how affordable food is. So food insecurity triggered by this global warming induced agricultural disturbance has led to a reliance on refined and ultra-processed foods. This has then led to epidemics of both obesity and undernutrition or malnutrition, both of which contribute to the development of non-alcoholic fatty liver disease. The development of NAFLD can then be compounded by the adoption of a sedentary lifestyle associated with obesity, and this in itself is associated with an increased reliance on motorised vehicles, for example. This and the increased healthcare resource use associated with obesity and with liver disease further contributes to the climate crisis through increased greenhouse gas emissions, and so the cycle and the relationship continues. So a few years ago, a publication in The Lancet really highlighted this problem as a global syndemic. That is, a synergistic epidemic of obesity, undernutrition and climate change. And it's clear now that this syndemic may lead to the development of metabolic liver disease. In fact, it's probably no coincidence that the NAFLD epidemic is paralleling the acceleration in the climate crisis. Therefore, it's really vital that we address the drivers of this syndemic urgently. Addressing these drivers will undoubtedly benefit both the patient and our planet, and may also have a role in the primary prevention of liver disease. For example, the use of active transport in place of motorised transport and a move towards a mostly plant-based diet are likely to positively impact upon climate and liver health. To address this syndemic, however, we need governments, global healthcare organisations and public health societies to work together to address the drivers of the syndemic. But this is absolutely vital to restoring and maintaining not only human liver but planetary health. So stress and eco-anxiety are also recognised impacts of climate change, and there's evidence to suggest that this is resulting in people consuming more alcohol. The role of alcohol in the climate change liver disease connection is again multifaceted. Production and distribution of alcohol has a significant environmental impact, and in this particular audience we're all well aware of the liver-related harms associated with alcohol. But looking at the environmental impact first, there are some data from Sweden, where alcohol production and consumption is responsible for around 3% of dietary greenhouse gas emissions. Interestingly, production and consumption of wine is associated with the greatest total greenhouse gas emissions, predominantly as a consequence of the agricultural process and packaging. We can then look at the carbon footprint of alcohol-related liver disease admissions and begin to understand the impact of these admissions to hospital on the environment and planet. So my colleagues in the south of England looked at the period of 1 year in Scotland and England, and this period was during the pandemic, so the numbers quoted here are relatively conservative, but they calculated the carbon footprint of alcohol-related liver disease specific admissions in Scotland and England and found the carbon footprint to be the equivalent of approximately 13,000 return transatlantic flights. I think these data are astonishing, and we urgently need more data like these to learn about how caring for our patients with liver disease is impacting upon the planet. Moving on, there have been a few studies within the past few years looking at the link between air pollution, particulate matter, and the development of liver disease, namely metabolic liver disease. Particulate matter is recognised to cause harmful effects through inflammation, insulin resistance and oxidative stress, which may play an important role in the development of chronic liver injury and cirrhosis. And certainly air pollution has been shown to cause stellate cell activation in mice. So this recent large cross-sectional study from China demonstrated that increased exposure levels to air pollutants were significantly associated with increased odds of metabolic associated fatty liver disease, and these effects were exacerbated by unhealthy lifestyles and central obesity. So once again, a vicious cycle between climate change and liver disease is noted. Similar results have also recently been reported from a UK biobank study, which also demonstrated that long-term exposure to air pollution was associated with risks of NAFLD and cirrhosis. There also appears to be a link between climate change and the development of liver cancer, and we've already touched upon increased aflatoxin as ambient temperatures rise and the development of cirrhosis secondary to fatty liver disease as potential risk factors for this. There's been some interesting work recently published from Australia looking at the link between climate change and a rapid increase in liver cancer cases which have been observed there, which couldn't be explained by a change in other epidemiological factors. The authors found a higher risk of liver cancer in those regions or territories with very high ambient temperatures, and although they postulate a number of contributing factors as shown on the figure here, they also consider a direct effect of climate change. This is certainly an interesting but worrying observation which warrants further study. With severe weather events due to climate change resulting in increased migration, we also need to be aware of the liver-specific healthcare needs of both refugees and migrants. So the climate crisis is causing flooding and coastal erosion around the globe, which exacerbates waterborne infections and can lead to epidemics of hepatitis A and E. Hepatitis A and E can also be acquired by refugees in camps due to poor sanitation, and the ongoing outbreak of hepatitis E in South Sudan is a prime example. The recent EASL-Lancet Commission recognised the problem of undiagnosed and untreated liver disease in migrant populations. In particular, I think we need to be aware of the increased rates of viral hepatitis, and we really need to scale up hepatitis B screening for migrant populations from endemic countries. Most migrants are not aware of their status. And currently, migrants from countries with high Delta prevalence are responsible for most new cases of Delta infection in Europe. And finally, there's a huge amount of stigma associated with both migration and a diagnosis of liver disease that we really need to work to address. So finally, for this section of my talk, in view of the increasing burden of liver disease that I've described and the possible increase in liver cancer cases, it's worth considering the climate impact of liver transplantation too, as the demand for this is likely to increase. Available data are limited, but we must take into account retrieval and transportation of organs, production and distribution of immunosuppression, attendance at transplant clinics remote from the recipient's home. And I'd like to just highlight two aspects here. So the first is travel to a dedicated liver transplant clinic. To try and illustrate the scale of the problem, I've taken a snapshot of just one liver transplant clinic in 3 transplant centres in the UK. So the distance and time quoted on the slide here are the quickest routes derived from Google Maps, so these figures are probably quite conservative. But let's take the clinic where I work in Edinburgh, for example, and these figures are for one clinic only. A total of over 2,300 miles were travelled by patients, with nearly 60 hours travel time. This is predominantly road travel with some air travel, but all of which is contributing to greenhouse gas emissions, and we run 2 of these clinics per week. So just think about the impact of that on the planet. Secondly, there are some published data describing the carbon footprint of organ acquisition in the US. For example, just looking at the use of chartered aircraft to transport donor livers, this produces at least 27,000 metric tonnes of carbon emissions per year, and this is only one part of the entire transplant process and journey. So again, some food for thought. So now that I've highlighted some of the ways that the climate crisis is impacting upon the development and burden of liver disease, let's move on to the concept of sustainable hepatology. There are 2 broad aspects here. One, how we as healthcare professionals can do better for our patients to reduce the impact of climate change on liver disease. And 2, how we can deliver a sustainable or green hepatology service to reduce the impact of caring for our liver patients upon the environment. Sustainable hepatology is a concept that involves taking the 4 pillars of sustainable healthcare, that is primary prevention, patient empowerment, lean service delivery and low carbon alternatives, and applying them to the management of patients with liver disease. I think focusing our efforts on the primary prevention of liver disease is the area of sustainable hepatology where we are most likely to have the greatest impact on both patients and the planet. As you will all be aware, 90% of liver disease, certainly in Western populations, is potentially preventable. And looking at the bigger global picture in relation to climate change, preventing liver disease will reduce healthcare contacts and reduce the environmental impact of our work. So examples of interventions that have been shown to have a role in primary prevention of liver disease include minimum unit pricing and alcohol taxation. In relation to obesity, we as healthcare professionals need to advocate for global society to have access to active transport and exercise, and for healthy foods to be accessible to all, which may require a change in policy, such as government subsidies. This is important though, as we know that a plant-based diet has a significantly lower carbon footprint than the average Western diet, up to 84% lower in fact when compared with animal source foods, and a plant-based diet has also been associated with a lower risk of incident NAFLD. Exercise and active travel are also important in the fight against both climate change and liver disease. There is good evidence that regular exercise reduces incident fatty liver, and switching just one trip a day from driving the car to cycling reduces an individual's carbon footprint by over 0.5 tonne per year. Looking at minimum unit pricing as a primary prevention example in a bit more detail, the most tangible association as to how this can impact upon the planet would be the reduction in healthcare associated greenhouse gas emissions as a result of reduced hospital admissions. Looking at the data that we have so far relating to liver disease specific admissions following the introduction of minimum unit pricing in Scotland, at the end of the first 2 years there was a small reduction in hospital admissions from liver disease. And a recent systematic review published in BMJ Open again looked at the impact of minimum unit pricing on all alcohol-related admissions. And again, they observed a reduction in admissions that would be expected to be associated with a reduction in healthcare-related greenhouse gas emissions. The second pillar of sustainable healthcare is patient empowerment and self-care, and I think this is more challenging to deliver on a global basis to patients with liver disease, as climate change disproportionately affects low-income populations who can experience digital poverty. Yet many of the self-care tools currently available to patients with liver disease are apps for smartphones which our patients may not have access to. In general terms, patient empowerment includes strategies such as patient-led follow-up, which could subsequently reduce waste and travel-related greenhouse gas emissions. However, there are little data regarding the safety and acceptance of patient-led follow-up in the hepatology patient population, and this is an area in need of research. Patient education regarding self-management and the impact of climate on health is urgently needed. In terms of digital apps, one novel and exciting self-care tool is SiroCare. So SiroCare is an app that allows for digital home monitoring for patients with cirrhosis. There was a study recently published in the Journal of Hepatology which aimed to assess the feasibility and patient engagement of SiroCare, and in addition looked at identifying those individuals at risk of decompensation to allow timely intervention. And we can infer that by timely intervention, hospital admissions may be reduced, and therefore the use of consumables and related production of greenhouse gases would be reduced also. In a small study of 20 patients, user engagement with the app was good, and the SiroCare managed patients had fewer admissions, they had shorter admissions compared with controls, and they also underwent a reduction in unplanned paracentesis. So I think this is promising technology worthy of further study, and I also think it would be useful to undertake some carbon footprinting work around the use of this app. The third pillar of sustainable healthcare is lean service delivery. So now is the time to change our existing care models to benefit both patients with liver disease and the planet. And many services, in fact, have been able to use COVID as a springboard for change. Globally, in relation to lean service delivery, I think the focus should be on where we deliver care, so namely delivering care closer to our patients, for example, through outreach services, and optimising our outpatient service, ensuring that there are no low-value contacts and no value contacts, and also putting in place to reduce DNA rates. In the UK, for example, hepatology has the highest outpatient DNA rate of all medical specialties, and reducing our DNA rate would be an example of running a leaner service. Looking at other hepatology-specific approaches, day-case large volume paracentesis is an example of lean service delivery. There are data from England showing that in patients with cirrhosis and ascites undergoing large volume paracentesis in the last year of life, those who attended a day-case service had almost 17 fewer inpatient bed days compared with those who had unscheduled care, and therefore a dedicated large volume paracentesis service is better for both the patient and the planet. And finally, we have low carbon alternatives. So globally, we need to be prioritising treatments and technologies with a lower environmental impact. The main problem here is that in terms of low carbon alternatives specific to hepatology, this is an evidence-free zone, and there are no real carbon footprint data for hepatology interventions or service delivery. This is something that I'm working on personally and hope to be able to share some data with you in the coming year or so. Virtual consultations may seem like an obvious win here, and I'll come on to that just shortly. It also seems intuitive that FibroScan, for example, would be associated with a lower environmental impact compared with liver biopsy, and that transnasal endoscopy would be associated with a lower environmental impact compared with conventional endoscopy, but we need the evidence to back that up. So I'll finish off by saying that virtual consultations and telemedicine are seen by many as the key or the solution to delivering an environmentally friendly hepatology service. There has been some work from Liverpool in the UK which looked at patient satisfaction with telemedicine in patients with autoimmune hepatitis, liver transplant and cirrhosis compared with patients with inflammatory bowel disease. And although the majority of patients were satisfied, for example with a telephone consultation, the percentage of satisfied patients was lower in those with liver disease compared with inflammatory bowel disease, and was lowest in patients with cirrhosis for a number of different consultation formats. There has also been some work looking at the tele-evaluation of patients being considered for liver transplant. However, again, this may disadvantage those poorer patients who are often most affected by climate change and experience low digital and health literacy. So of course we absolutely need to keep the environment in mind, but we also need to do what's right for our patients, and I don't think that telemedicine is the panacea to delivering a sustainable hepatology service. To conclude, in addition to raising awareness as to why climate change is relevant to us as healthcare professionals looking after patients with liver disease, this talk is a call to action. We as healthcare professionals are used to being advocates for health in a range of other domains. Now climate change needs to become a priority for us, and we need to advocate for action because we are responsible for both the healthcare service and the planet of the future. Now this is a self-selected audience here today. Going forwards, please do take all opportunities to raise awareness of the climate change liver disease connection with colleagues and patients alike. Practically, on a day-to-day basis, you can consider all patient contacts to reduce low and no value contacts. So I personally review each clinic and endoscopy list well in advance with this in mind. Try and use non-invasive screening and testing where able, and promote research within this area. We need to move forwards. So with that, I will draw this talk to a close, and I look forward to taking any questions in the discussion. Thank you for listening.
Thank you, Dr. Donnelly. Please, team, could you please turn on my camera?
I say the same. Thank you, Dr. Donnelly.
Okay, thank you. Thank you, Chen.
Professor Talley.
Okay, now I give the floor to the moderators for the discussion.
It's very interesting double presentation. I see that we are 114 participants. Hope the second time we will be 1,000, not 100. I think we are in the beginning of this experience, and of course we need a collaboration of everybody and the collaboration of all the societies to make more advance in climate change. We need also to have a recommendation with the time to give recommendation for all the societies, and the societies give recommendation for the doctors, of course, to reduce CO2 elimination in the area. I think we need a lot of work, and we are ready to collaborate with the panel of experts. I don't have a question actually, but we let maybe the participant ask a question about the presentation.
Yes, actually, I found there are some questions from the board. And so first, thank you to speakers, gave us such an excellent presentation. And then I found that there's several questions. Let's answer the questions first, and then maybe Mary is online, and some of our panelists online, we can answer some questions. Let me show from the first one. Oh, there's Erica asked, what can industry do, in particularly AER manufacturers? Any panelists can answer this question? Yes, Des?
Well, let's see. Mhairi, do you have a comment on that? I think you touched on that in terms of some of the medications that you showed us. What do you think industry can do?
Well, I think that the first thing that we need to do is make industry aware that we are looking at this as a problem and looking to tackle this, and ask industry to provide carbon footprinting data for medication production, for example, for the production of acidic drains, so that we as doctors on the ground floor can select products which are more environmentally sustainable.
Yes. Also, there is another question similar to this, that is from Todd. He asked, couldn't our GI societies provide specific guidelines for practice management, and in that way set the standards for how we practice, with recommendations on reusing materials, decreasing use of plastics, standards for energy use in buildings and travels, guidelines for choices? I feel that our vendors will not respond with climate-friendly products unless we establish the standards. That's really a good suggestion. How about a green practice certificate from our organizations? Maybe we, WGO, can do something on that. And Mary or our panelists?
So I mean,
want to take that one, or Mhairi?
I think Bashir would be better placed. I'll maybe hand him to him first.
Yeah, hi everyone. Fantastic talks, Professor Donnelly and Professor Talley. I don't think Dr. Talley was able to join us, but really enjoyed the presentations. A lot of information that I think all of us can learn from. So in terms of the specifics, I think working with industry or even working with practitioners, it would be, I would imagine that it would be helpful for them if we provide them with specifics. So at the level of the organizations, for example, I mean, just saying, decarbonize, I think, for example, how do you carbonize? So in the, for example, Mary, in the context of liver disease, you know, paracentesis, for example, with industry, the packaging and so on of the different, you know, needles, containers, things of that sort, and then delivery to the lab. I wonder if, are there any specific sort of guidelines that can help hepatologists, centers or units that do paracentesis or sort of, I mean, that would be one example, but I don't, and also in terms of the impact of this.
So in short, there's no guidance in that area at all. And really there's a lack of data in the field of hepatology altogether. So this is something that I am looking at personally, and I'm looking to study the carbon footprint of an unscheduled admission for large volume paracentesis versus, for example, a day case paracentesis service versus long-term abdominal drains. And I think that would be a really interesting place to start. Assess the environmental impact of those three different approaches to managing a patient with ascites, and that would provide us as hepatologists with some baseline information, because at the moment there is absolutely nothing out there to produce a guidance document upon.
That's what I said in the beginning. We had a hard work to make a recommendation for everything and to send it to the societies and to the doctor. We have a hard work, That's what we have to do, to have a recommendation. With the recommendation, we can do a lot.
I have one question, another question for Dr. Donnelly. So in terms of, you mentioned, you showed the data about comparing, for example, patients with liver disease, cirrhosis versus IBD, about some overall there was satisfaction, but there were some concerns. I wonder if, were there any specifics about the concerns that maybe could be highlighted, and if there's any ways to kind of address those concerns?
So one of the concerns is the access to technology in patients with liver disease. So having the actual smartphone or computer screen to undertake a virtual consultation, for example. The main issue here obviously is that climate change does disproportionately affect lower income populations who can't afford technology like that. There's no sort of immediate or quick fix to that, but I think we need to think outside the box as to how we can engage these patients in that sort of service.
Thank you.
Could I perhaps ask Dr. Donnelly? Thank you very, very much. Can you hear me?
Yes.
Jeffrey, here, look, I think that the science is wonderful and the presentations were very, very clear. Do we have a strategy as to how we can convince the industry and convince the politicians and convince the population that what we are saying is correct, and how we go forward with them rather than fighting against them? Do you have a strategy in the UK in that respect?
So, I mean, my main strategy over the past year has been focusing on raising awareness of this as an issue. And I've spoken on this topic on a number of occasions now, but I've come across a number of barriers. I think clinicians simply don't understand the gravity of the problem, and there seems to be a lot of barriers for people putting in place in day-to-day practice small things that can make an impact, but they don't realize that it can. So I think through strategies like this climate course, we can hopefully make some progress. But as Elias has touched on, I think the key here really is working together to take forward more, what's the best way of putting this, more formalized proposals to government agencies, for example, to take this forward. But the data are lacking at the moment really to facilitate that, I think, in terms of hepatology.
Thank you.
Yes. Dr. Donnelly, I have a question. Except we try to make our voices heard, do you think it's possible to do some studies to answer what we are talking about, to persuade the government or the industries to do something? And or do you think it's possible we first accepted to educate the patient, but more priority is to educate our doctors, to let them to do some like studies to show more direct or solid evidence to support us, such as, for example, how to restrict our endoscopic indications. Like maybe, you know, especially in China, there's so many people take the procedure of the endoscopy, but maybe that is not only the age over 40 or 45, or maybe you need to do something. We need more restrict alarming symptoms to do the endoscopy. Do you think it's possible to do some studies on it?
I think we absolutely need to, because without that evidence base, I think we're really going to struggle to convince patients and clinicians that there is a problem here that we need to deal with and propose a strategy as to how to manage that. So I've actually got some time coming up in the next 3 years to focus on research studies in this area. So fingers crossed I might be able to make some progress in relation to hepatology. I think your point about endoscopy is interesting, and you know, you'll be aware there is a big green endoscopy movement who are working on that. I guess one of the things from a hepatology perspective that we could look at is the environmental impact, for example, of using the Bovino criteria to select patients for varicose screening versus blanket screening everyone with a new diagnosis of cirrhosis. But again, we need some evidence to really back that up.
Thank you.
Well, we are at the end of the session. So I would like to thank the presenters, the moderators, and participants. I want to remind you that this is a bi-weekly webinar series, and next session number 3, about food, water security, and vulnerable populations will take place on April 5th. A recording of this webinar will be available at WHO website, and an email with the link will be sent to all the registrants. And we are in the process of applying for CME credits for this course. Thank you very much to all of you. Thank you.